and thank you everyone for being here. My name is Dr. Emma Grote, and I'm the Navian Medical Director. And today I'm going to be talking a bit about the benefits of hospice and palliative care in people with advanced dementia. I wanted to take a moment to thank our sponsors, Hale Koike, Navian, Catholic Charities of Hawaii, and the Administration of Community Living. During this talk today, I'm going to review what hospice and palliative care are, discuss some of the criteria for hospice admission, and look at some of the common complications that occur in end-stage dementia, as well as some of the burdensome interventions that frequently occur near end of life. I'm also going to review some of the benefits of hospice and palliative care in patients and their families. I wanted to take a moment to tell you a bit about my grandfather, Jack. This is a picture of him with me during my medical school graduation. Jack was a very intelligent man. After he retired, he went to UH for about 2 decades to learn the French language, to learn the Pali language, so that he could review texts from Buddhist times to really get to know that. He was diagnosed about a year prior to my graduation with vascular dementia. At that time, he had some short-term memory loss, as well as some problems with executive function. He ended up succumbing to the disease about 12 years after he was diagnosed. But throughout that journey, my family and his wife played a huge role in supporting him and each other through this process. He gave me incredible insight when he was well into Buddhism, into the power of meditation, and into the power of teaching. And whenever I have a chance to speak with people about dementia, whether it's in a lecture or in their homes, I really feel like it's an opportunity to honor my grandfather and to honor my family in what we have done with him through this journey. So thank you. So in the United States, dementia is quite a problem. There's almost 6 million Americans who are living with Alzheimer's disease currently, and it's expected that by the year 2060, over 14 million people will be affected by the disease. In the United States currently, it's the 6th leading cause of death, and in those over the age of 65, it's the 5th leading cause of death. Palliative care is very important in people who are given a diagnosis of a chronic terminal illness. And unfortunately, dementia is not necessarily viewed by a lot of clinicians right now as a terminal disease. But we know that much like many cancers and heart and lung disease, we expect that over time it will progress and we don't necessarily have a cure for it. Because of that, palliative care is an important thing to be introduced to people who are given the diagnosis of dementia. The goal of palliative care is to improve life, both for the patients and the family and caregivers. The focus of palliative care is on symptom management, on other stresses that occur for the illness, and also on ensuring that families and patients understand their disease process, how it will progress, and make sure that they're able to make informed choices for the medical treatment that they will be receiving. It's based on the needs of the patient, not on a patient's overall prognosis. So it can occur at the time of diagnosis, even when patients are still thinking about pursuing aggressive treatments. It involves not only a medical team of a physician and nurse, but also involves social workers and spiritual support to make it a holistic care plan. There are many benefits that they have found for palliative care. Patients have overall better symptom management. They have decreased incidence of anxiety and depression. They've also found that the care that patients who have palliative care receive aligns more closely with their values, goals, and preferences. In patients who receive palliative care, they find that in the last month of life, they are less likely to be hospitalized, and in those who are hospitalized, the hospitalization is less intensive. They've also found that caregivers report less distress in the last 3 months of life in patients who have received palliative care. Hospice care is a specialized type of palliative care, and it focuses on caring for people who are in the last 6 months of life. Much like palliative care, we focus on aggressive symptom management and a holistic support of patients and families looking at quality of life. It also offers other services like assistance with activities of daily living, such as bathing, and also provides grief and bereavement counseling, not only for the patient, but also for the family a year after the death of a loved one. Hospice care can occur anywhere, at a patient's home, at a foster home, or in a nursing facility. It has a core team similar to a palliative care team, as well as nurses, assistants, and volunteers who play an important part in the care of hospice patients. In an ideal world, palliative care would start as soon as a patient is given a diagnosis of a chronic life-limiting disease. Initially, at that time, patients are struggling to understand their disease process. They're struggling to overcome new symptoms. And while the medical model of treating that disease does a fine job, the palliative medicine model, focusing not only on quantity of life, but also quality of life, is very important. As a chronic disease continues to worsen, often the medical interventions which can be done decrease. And as this happens, palliative medicine and the focus on quality becomes more and more important. Eventually, a patient will reach the point where no further aggressive medical interventions will improve quality of life, and that's where hospice can come in. At that time, hospice will continue to follow the patient and the family until death, and will continue to follow the family for over a year afterwards, providing bereavement support and counseling. Prognosticating patients' lifespan in dementia is particularly difficult. It ranges anywhere from 3 to 12 years, and they have found that patients who have a diagnosis of vascular or Lewy body dementia often have a shorter prognosis. Not surprisingly, patients who are diagnosed at a later age also have a shorter survival rate. Unlike some other chronic diseases like cancer, heart, and lung disease, dementia is very difficult to prognosticate as far as time. This bar graph below shows the number of patients on hospice with a particular condition. And you'll see that by far and away, cancer patients are the most robust group of patients that are served by hospices, followed by heart and lung disease, and then dementia. One of the reasons for this is because the terminal phase in a cancer patient's life is fairly predictable. In this graph here, you see health status on the left and time before death on the lower axis. And we usually see in cancer patients that once they start to have significant functional decline, it will decrease at a pretty steady level until the time of death. This is very different than the terminal disease phases that we see in patients with dementia and chronic heart and lung disease. There on the right, you see a graph of patients with heart and lung disease. And often these patients will have an acute exacerbation that results perhaps in a hospitalization or aggressive interventions with breathing treatments and medications for the heart that allow them to get better. And over time, while they will have a decrease in function, they will continue to have these acute exacerbations until eventually there's an acute exacerbation where either medical interventions are ineffective or family and patient have decided not to have any intervention, and that leads to death. The trajectory for patients with dementia is much different. We find that when these patients are often in their last years of life, they already have a very low function with significant physical and cognitive defects, deficiencies. As a patient with dementia continues to decline, these complications of infection are often punctuated by delirium and further functional and cognitive decline that occur until the time of death. In order for a patient to be admitted onto hospice, Medicare has laid out some specific criteria for us to follow to ensure that they meet this prognosis of 6 months or less. Currently, the Medicare hospice criteria for end-stage dementia requires that a patient is at a level of a FAST score of 7C. And what this means is that patients are dependent with all activities of daily living with minimal verbal ability. They also require that a patient has had one of the 6 medical complications listed below, as these are often a harbinger for death. In 2010, people started to realizing that those prognostication tools were not so well, tried to find other prognostication tools to see if perhaps we could get a better understanding of what things a person would show that would bring them closer to death. This was a study done in 2010, and it looked at 600 nursing home patients with end-stage dementia. In this, they found they used many of the same criteria that we used in the Medicare guidelines, but also added a recent nursing home stay, as this often occurs when patients have just had an acute hospitalization and are coming out. Age, if a patient was older age, they were given more risk points. Males were given a higher risk point, as well as symptoms of shortness of breath, a low body mass index, and a history of congestive heart failure. In this study of 600 people, they found that about 10% of the patients actually qualified for hospice at the time of diagnosis, at the time that the study was going on. Yet over 18% of patients died during that time period, letting us know that the Medicare criteria were not so useful. Unfortunately, this ADEPT tool did not show much improvement than the Medicare model in diagnosing patients with prognosis of 6 months or less. What this did show us, though, is that in patients with dementia, because establishing prognosis is so difficult, care should be provided based on goals rather than life expectancy. And this is an important paradigm shift for both clinicians and for caregivers to understand moving forward when patients have an end-stage dementia. This is a graph that shows the average length of stay for patients on hospice, broken up by different diagnoses. And you see that Alzheimer's, dementia, and Parkinson's by far and away have one of the longest average lengths of stay. And I think part of this is secondary to the difficulty with prognostication in this population. It's not unusual for us to have a patient who comes on to hospice after a aspiration pneumonia or after a urinary tract infection, and they come on to hospice looking like they're at death's door. But after a few months of good, consistent care, they kind of stabilize to a new baseline, and they may end up being discharged from hospice services, sometimes up to a year or two before they have another event where they may then be readmitted onto hospice before finally passing away. Of all of the different diagnoses that come onto hospice, I would say the dementias are the ones most frequently discharged from hospice because they're at a place where they have a life expectancy greater than 6 months or less, and then readmitted at a later date. So considerations for both clinicians and caregivers are realizing that care needs to be provided by the goals of care for a patient rather than life expectancy. One thing I will often counsel clinicians in is asking them the question, would you be surprised if this patient died in the next year? If that would not be surprising to a clinician or even a family member, I think looking at ensuring that the advanced healthcare directives are up to date, making sure that family members understand the complications that may occur, and considering a consultation to a palliative care service or even a hospice service are very important to ensure that that patient has care that is in line with their goals. There was a study done that looked at choices, attitudes, and strategies for care of the patients with advanced dementia at end of life. And this was done as we have realized that more and more people with dementia are living longer, and we didn't really have a great idea of what the disease trajectory looked like and the clinical course of advanced dementia. In particular, this study looked at resident comfort, things that went into clinical decision-making, as well as family satisfaction with end-of-life care. This study was done over a 2-year period, and it followed 323 nursing home residents with advanced dementia, as well as their healthcare proxies. It followed these patients over an 18-month period, and some of the endpoints that it looked at included survival, common clinical complications, symptoms that they had, and treatments that they received. And it also looked at what the healthcare proxies understood about a patient's prognosis and expected clinical complications, and how that affected outcomes in a patient's care. In this study, the mean survival was 1.3 years, and a little over half of the patients passed away by the end of the study. Distressing symptoms were common, and shortness of breath and pain were those that were most seen. Other acute illnesses, such as heart attack and stroke, were very rare in the last 3 months of life. They also found that 40% of patients had a burdensome intervention. This would be something like a hospitalization or ER visit, or any kind of invasive therapy. They found that the most common complications in these patient population was pneumonia, febrile episodes, and eating problems. And that when these problems arose, it definitely increased their 6-month mortality. Eating problems were by far and away the most frequently seen complication of end-stage dementia, with over 80% of them having it. Eating problems are caused by many different things. Patients' functional decline as well as inattention complicate the task of eating. Not only do they have more problems getting the food to their mouths, but their swallow is affected, such that pocketing or spitting food can become common. And when they're actually able to swallow the food, it's not uncommon that they are unable to swallow effectively, increasing the risk of food going down into the lungs, causing an aspiration pneumonia. When this occurs acutely in a patient, we often need to rule out some reversible cause. And you'll see that infections, stroke, sometimes medications, something as simple as constipation can also cause some eating problems. It's important that families understand that dysphagia and anorexia will only become worse as the disease progresses. There is some evidence out there that the high-calorie supplements like Boost and Ensure will promote weight gain. However, there's no great evidence that this is muscle weight. They have found that appetite stimulants don't really work and also come with their own side effects that have to be worried about. They've also shown no evidence that even with increased nutrition and weight gain, that there's any improvement in cognition, function, or overall mortality. Back in the 1990s, with the advent of percutaneous endoscopically placed G tubes or feeding tubes, a lot of people started to look at that as an option in people with end-stage dementia to allow them to receive more nutrition. There have been many studies since then that have shown that when tube feedings are placed in a person with advanced dementia, there is no improvement in overall survival, nutritional status, the formation of pressure ulcers, or the incidence of aspiration pneumonia. In fact, there are risks associated with feeding tubes, including an increased need for ER visits, to unblock a tube or replace a dislodged tube. In these patients, there's often an increased use of restraints, either physical or chemical, to prevent them from pulling the tube out. It's also been found to increase the risk for new pressure ulcers. Because of this, the American Association of Hospice and Palliative Medicine, the American Geriatric Society, and the Alzheimer's Association all discourage feeding tube placement in patients with advanced dementia. Pleasure feeding is a wonderful way to stay connected with people with end-stage dementia. And this allows food and drink for the patient's pleasure. There are many benefits to hand feeding a patient. First and foremost is the pleasure of the person being able to taste the food. And at a time when interacting with a person becomes more difficult, being able to eat together, being able to interact with family members may be some of the most concentrated time that a person with dementia actually has with someone one-on-one. Some strategies for feeding include minimizing distractions. Often offering favorite foods can have them eat a little bit more. Sometimes we find that sweets are more frequently preferred. Ensuring the right consistency is very important. As the dysphagia worsens, it's not uncommon for us to have to puree foods or chop them up a little bit more finely. Providing utensils that perhaps are a little thicker so that patients are able to hold them more easily, or providing finger foods can also allow patients to be more independent in eating. And realizing that scheduling breakfast, lunch, and dinner on the normal cycle isn't always the best for these patients. Rather, scheduling when they are more alert is very important. It's important that we empower caregivers when discussing these eating problems. As a clinician, it's important to offer society recommendations when discussing this. There have been multiple studies that have shown that in offering society recommendations and educating about these complications, caregivers have a reduction in the decisional conflict they feel and an increased overall knowledge. Speech evaluation and dietary consultation can be very helpful to not only provide hands-on training for the caregivers, but also to provide suggestions about textures and ways to increase the caloric intake. There are some wonderful online resources as well about dysphagia and dementia. I would point you to our very own geriatric department at JABSOM that has a wonderful page filled with information as well as a video on feeding people with dysphagia. Pneumonia is another common complication. And in that cascade trial that I was speaking of earlier, they found that 41% of patients had a pneumonia. And when they had that pneumonia, there was a 46% chance of passing away within 6 months. In those patients who had a pneumonia, they found that almost 70% of them had more than one episode of pneumonia during the time period that they were studied. This was something very interesting to me, and that was a study done to look at what the treatment of pneumonia did for a person in terms of overall survival as well as comfort. This looked at the patients who had developed a pneumonia during that time period, and it looked at what type of antimicrobial, what kind of antibiotic they received, as well as their SMEOLD score, which is a comfort score, with a higher score meaning greater comfort. And this was a score that was done by the nurses who were looking after that patient. What they found was that antibiotics definitely increase survival rate. You're looking at 6 to 9 month increased survival rate in those who received antibiotics. And there wasn't a huge difference between whether the antibiotics were oral, intramuscular, or intravenous. The interesting thing I found was that those who did not receive antibiotics actually had a higher comfort score than those who did receive antibiotics. And in those who received antibiotics, they found that those who needed IV antibiotics or hospitalization had the lowest comfort scores of all. Why this happened is a bit of a mystery, but some of the thoughts behind the higher comfort scores was that when patients are treated medically for a pneumonia, there is more time spent trying to give them medications, which can cause pain. It can cause anxiety or agitation as they're being needed to give medications 2 to 4 times a day. Sometimes it can cause the need for restraints if a patient has an IV in, and the time that patients are having an interaction may be more medicalized, and there may be less interaction that focuses on comfort and being with a person human to human. As a clinician, I think it's important that we let caregivers know that infections and pneumonia are a natural part of disease progression and a common pathway to death in patients with advanced dementia. And again, treatment should be based on goals of care. If a patient's goal and a family's goal really is comfort, then perhaps no antibiotics is the way to go, with aggressive palliation of symptoms of shortness and breath and pain that they may have. Or if the family feels that the potential burden of antibiotics is outweighed by a longer life expectancy, then doing a trial of antibiotics which is not associated with such lower comfort levels, such as oral or intramuscular antibiotics would be the way to go. And again, if we're looking to prolong life, trying to do either oral or intramuscular antibiotics so that we are not causing them undue discomfort. Hospitalization in end-stage dementia is a common thing. And unfortunately, about 15% of people with dementia actually die while still in the hospital. In the Cascade study, they found that 20% of nursing home patients had some type of burdensome transfer near the end of life. The infections were the #1 cause of a hospitalization. And for people with comfort-focused care, I think one key thing is to speak to families about having a do not hospitalize order if they are in a nursing home, because we know that hospitals in particular can be a scary, uncomfortable place for patients when they are out of their usual setting, having interventions done by people they are not familiar with. I wanted to quickly go back to the pop quiz that we started the session with and just review some of those answers. We'll still be talking about some of these shortly though. So careful hand feeding for people with severe dementia is at least as good as tube feedings for outcomes such as death, aspiration pneumonia, functional status, and patient comfort. And this is definitely true, as we have just discussed. As we have found out, eligibility guidelines for admitting patients with dementia do not accurately predict survival. So this statement is false. Treating pneumonia with antibiotics in people with severe dementia increases comfort level. Again, not true. Patients with dementia at end of life suffer a burden of symptoms similar to that of patients with cancer. This is true, as we will soon be learning about. and better counseling of healthcare proxies and advanced healthcare directives are consistently shown to improve palliative care outcomes in people with dementia. This is true, as we have been discussing, making sure that families are aware of the complications that might come as the disease progresses and are able to make sure that these wishes for comfort are known definitely improves comfort near the end of life. Going back to the advanced healthcare directives, because I really think that's important. I think it's important for us as clinicians to realize that dementia is a terminal disease and try and start those conversations as soon as a diagnosis is given. Educating family on the complications that we expect down the road and allowing them to think about them at that time rather than at the time a pneumonia has hit can make sure that they are acting from a place of what's best for the patient and not necessarily a place where they are scared and seeing a sick one suffer. And it's important that we revisit the advanced healthcare directives as they will likely change with disease progression. For family members and healthcare proxies, starting conversations with their loved ones early on in the diagnosis is very important. Kuamau has a wonderful website with a lot of resources on starting these conversations. There are some resources particular to people with dementia, as well as some pointers on how to get these conversations started and what things in particular you might want to speak with your loved one about. I think as a family and healthcare proxy, it's important to realize that directives change as the disease progresses and kind of focusing on what is most important for my loved one and what they would want will likely change as the quality of their life changes with disease progression. I think ensuring that family members have this knowledge is extraordinarily important in burdensome interventions, and this was also shown in the Cascade trial. If you see in the little red box there in the middle, this looks at patients who underwent a burdensome intervention in the last 3 months of life. And what they found, if you look there at the bottom, is that proxies, healthcare proxies who did not believe a resident had 6 months or less to live and did not understand the expected outcome, in these patients, 72% received a burdensome intervention. In proxies who either believed that a patient had less than 6 months or who understood the complications, only about 40% of those patients received a burdensome intervention. And in proxies who understood the complications and also believed that a patient had 6 months or less to live, only 27% of these patients received a burdensome intervention in the last 6 months of life. I think this really is solid proof that knowledge is power, and ensuring that caregivers understand the complications as well as the potential prognosis can really help prevent actions that may be less comforting in the last 3 months of life. So do patients suffer in the end stages of dementia? We know that they do, but some surprising evidence is out there that they may suffer just as much as patients with cancer. This was a study done in bereaved family members who had looked after either patients with cancer or patients with dementia. And this looked at suffering in several domains there on the left in the last year that they were alive. Dementia is the bar graph that's black, and cancer is the bar graph that is gray. And in all of these, they found that patients with dementia suffered more and at a more higher rate than those with cancer. There have been a few other studies that have also shown that patients with dementia suffer rates of shortness of breath and agitation that are just as high as patients with cancer, although patients with cancer may have pain rates that are a little higher than those with dementia. In the Cascade study, they also found that patients suffered with distressing symptoms, and that as they became closer to the end of their lives, the incidence of these symptoms increased. In particular, shortness of breath was seen often, complications related to difficulty feeding, as well as agitation were frequently seen. Assessing distress in this patient population can be very difficult, and there are many tools out there that can help us ensure that a patient is comfortable. One that we frequently use on our service is the pain ad, which requires us to watch a person for 2 to 5 minutes and look at their activity level, their facial grimacing, vocalizations, to see if they are uncomfortable or not. And again, depending on what the goals of care are, will really drive the intervention to some of these distressing symptoms. For instance, if goals of care are more life prolonging and we see that a patient is suffering with shortness of breath, we may end up doing a chest x-ray, drawing labs, and doing IV antibiotics to treat that dyspnea. Whereas if it's more of a comfort directed approach of care, we may look at starting some oxygen, starting some medications to help with the shortness of breath. Again, advanced healthcare directives and goals of care are going to be important in treating these distressing symptoms. This is the pain ad, and this is what we will often use when we are looking at whether or not a person is uncomfortable. There are many benefits of hospice care for patients with end-stage dementia. They have found that these patients often have an increased assessment and treatment for both pain and shortness of breath. There's also a lower rate of physical restraints used in this patient population, and also a lower rate of burdensome interventions. Families also report a greater satisfaction with care during end of life in patients who have received hospice services. But the benefits are also for the caregivers. This was a study that looked at caregivers' responses to patients who had end-stage dementia in those receiving hospice versus those who did not receive hospice. And they found that in the patients who received hospice care, family members felt that pain was better managed, that they had a better idea of what to expect while the patient was dying, as well as what to do at the time of death. They also felt that they had better spiritual and emotional support before the death occurred. In conclusion, educating caregivers can impact burdensome interventions at the end of life. And because of this, palliative care should be introduced earlier in the disease trajectory. Whether or not this palliative care is done by a patient's primary care physician or a palliative care team depends on the comfort level of the primary care physician and the availability of palliative care. Treatment of complications should really be guided by goals of care and not prognosis, because we know that that is a difficult thing to assess. And hospice improves patient comfort and caregiver satisfaction during the dying process. I want to end the presentation with this slide. There you'll see my grandmother there on the left, and there's Jack all the way on the right side of the couch with my family around him. We were really blessed to have my grandmother who wanted to keep my grandfather at home, and a lot of willing family members who were able to support her and support him in his journey with dementia. He ended up passing away about 12 years after the diagnosis. The last 2 years were pretty much bedbound and dependent for all care. When he did pass away, we had had him on hospice services for about 3 months, and he passed away from complications of an aspiration pneumonia. It was a difficult passing for everyone involved, but we were able to ensure that he did not suffer, and the fact that he was at home with people who loved him and around him was really a wonderful gift that my family was able to make happen. I'm very grateful for that. Here are some selected references. Thank you all for coming. I appreciate your time, and I appreciate the good work that you are doing in the community and for your loved ones. Thank you.